So let's now talk about arterial disorders. And in arterial disorders, the first topic which we need to talk about is acute arterial occlusion. Now, acute arterial occlusion is secondary to an embolus, and the source of this embolus is usually the heart. So the source of the embolus is usually the heart. Sometimes it can be an aneurysm, like an aortic aneurysm can also shower off emboli, which can go distally and block the vessels. But usually the source is the heart. And what are the key words which you should look out for in the question if you're given such a question? So you will get keywords like atrial fibrillation or irregular heartbeat. Irregular heartbeat. And this basically says that because of this irregular heartbeat, because of atrial fibrillation, there can be emboli which can form in the heart and they can be showered off distally and they can block the vessel. Now, because this is acute occlusion, there is no time for the formation of collaterals. So the clinical features with which these patients are going to come are 6 Ps. And these 6 Ps have been asked very frequently in the exam. So the 6 Ps which you get are pain, pallor, that means the limb is going to become white. There's going to be paresis, there's going to be weakness, paresthesias are going to be there. Poikilothermia is that the limb will become cold and you can have pulselessness. And there can be pulselessness, right? Now, one thing which I want to tell you here, that for the sake of remembering, I've given 6 Ps and I've given paresthesias, but usually there is complete loss of sensation. There is usually complete loss of sensation when there is an acute embolic block. Complete loss of sensation is present. And pulselessness, I want you to know, is a late sign. So just don't go by pulselessness. You should look at the entire picture in totality and look at these 6 signs which are there. Now, when you have a patient with acute arterial occlusion, the investigation of choice in these patients is a duplex scan. We've already covered duplex. Duplex is a Doppler with a B-mode ultrasound. This is where what will localize the site of block for us. Now, on a duplex scan, a normal vessel has triphasic flow. There is triphasic flow. This question has been asked in the exam. And we've already discussed in duplex scan, it tells us about the direction of flow. It tells us about reflux. Those are the things which we'll get to know on a duplex scan. And of course, we get to know the site of the block as well. Now, acute arterial occlusion, you can see here that this embolus has come all of a sudden and it has blocked the vessel. And because there is no time for the formation of collaterals, the symptoms are severe and dramatic, like I've just explained to you. So the management in these patients, the management of acute arterial occlusion. Now, if the patient comes to us early, by early we means if the patient comes within 6 to 8 hours of the onset of pain or the onset of the emboli, then the limb can be salvaged. And how do we salvage the limb? We can either carry out thrombolysis, right? Either thrombolysis can be carried out. We can use streptokinase or other thrombolytic agents. But the contraindications for thrombolysis are bleeding disorders, or if there is a recent stroke. These are the contraindications where thrombolysis cannot be used. The other way is to carry out an embolectomy. And how do we carry out an embolectomy? We use Fogarty's balloons. These Fogarty's balloons have been asked in the exam. We use Fogarty's balloons to carry out embolectomy. Let me just show you what Fogarty's balloons look like. So this is a Fogarty's balloons. It is there in the deflated state. You pass it beyond the vessel. You can see here, we've gone beyond the vessel and then we inflate it. When we inflate it and we pull it back, it will pull out the embolus along with it. So this is Fogarty's balloons. We should always use heparin in these patients to prevent propagation of the thrombus, to prevent propagation of the embolus. We should always use heparin in these patients. Now, like I was telling you, the management, if the patient comes early, these are the 2 treatment options which we have. But if the patient comes late to us, where gangrene has already set in, Now, when gangrene has already set in, we wait for the line of demarcation to appear, and then we need to carry out amputation. Now, one more thing which I want you to know. Now, whether you do thrombolysis or you do embolectomy, there can be reperfusion injury. When the blood flow is re-established, there can be reperfusion injury due to free radicals. So this reperfusion injury can give rise to swelling of the muscles, and this can predispose the patient to compartment syndrome. Which is why it is said that if you get a patient with acute arterial occlusion, we should carry out a fasciotomy along with embolectomy. A fasciotomy should be done along with embolectomy to prevent compartment syndrome. And compartment syndrome we've covered at various places. It would have been covered in orthopedics as well. In compartment syndrome, there is excessive pain which is not relieved by medicines. There is pain on passive stretching. That is another sign. There's pain on passive stretching. And pulsations can be normal. So don't get swayed away. If the pulsations are present, that does not rule out compartment syndrome. And in these patients who are undergoing an embolectomy or thrombolysis, do a prophylactic fasciotomy to prevent reperfusion injury. We've also discussed that when we do a fasciotomy, we go down, we incise till the deep fascia. So we're going to incise the deep fascia as well. That is an adequate fasciotomy. So we can even do an angiography. You can see here that there was a patient where this was the blocked area, and once an angioplasty has been done, then you can see the blockade has opened up. So this can also reveal to us that the blockade has opened up. This was regarding acute arterial occlusion. Let's move on to chronic arterial occlusion now. Now, chronic arterial occlusion is because of a thrombus, and you can see here in a thrombus this is gradual occlusion, or chronic arterial occlusion is because of a thrombus which starts here, and as the thrombus keeps on increasing in size, it will block the vessel. But because this is a gradual process, what is going to happen? Collaterals will form. And these collaterals are going to supply below the blocked area as well. So even the area below the block, some bit of it will receive supply because of these collaterals. And these collaterals contribute to the distal runoff. Distal runoff means that even distal to the site of the block, there will be some blood supply which will be coming in. Now, how do these patients with chronic arterial occlusion present to us? So these patients, the clinical features of chronic arterial occlusion, these patients are going to come with intermittent claudication. Intermittent claudication means that at rest, there is adequate blood supply, right? At rest, there is adequate blood supply which is there. But when these patients start exercising or they start walking, then the blood supply to the muscles distal to the block is reduced. And these patients are going to come with cramping pain. This is cramping pain after walking a certain distance. And this is known as intermittent claudication. This pain is known as the pain of intermittent claudication. Now, as the block increases, the claudication distance will reduce. So if the patient initially was able to walk 1 kilometer and then get the pain, as the block increases, the pain will occur at 750 meters, then 500 meters, then 250 meters. Eventually, the patient will land up with rest pain as well. So as the block increases, claudication distance will reduce. Eventually, the patient lands up with rest pain. As the name suggests, this is pain at rest. And it is worse at night. and the patient gets some relief. The patient gets some relief when he hangs his leg down. When he hangs leg down, that is when he's going to get some relief. This is what you need to elicit in the history as well. If you get a patient of arterial occlusion or gangrene, you should ask this finding that do you have pain at rest also? Is it relieved when you hang your leg down? These are questions which you should ask in the history as well. Now, there is a Boyd's classification for claudication which you should know about. This Boyd's classification also you should know once an MCQ has been asked, and also this is asked in the Viva. This is for claudication. Pain on walking, but pain reduces as the patient continues to walk. So as the patient continues to walk, substance P, which is potassium, which is causing the pain, that gets diluted off and the pain will reduce. So that is class 1. Where there is pain, but as the patient keeps on walking, pain will reduce. Class 2 is there is pain on walking, but the patient continues to walk despite the pain. Patient continues to walk despite the pain. Class 3 is pain forces the patient to stop and the patient has to take some rest. And class 4 is rest pain, which I've told you is worse at night and it is slightly relieved when the patient hangs his leg down. This is the Boyd's classification. You can also have a Fontaine and Rutherford classification for claudication. But what has been mainly asked is the Boyd's classification. So only if you're preparing for the super specialty exam or the INI-CET exam, then try to remember the details of Fontaine and Rutherford. Otherwise, only Boyd is good enough for your exam. Now, one more thing which you need to remember is that you can sometimes have a patient of neurogenic claudication or osteoarthritis also walk into the surgery OPD. And your professor will ask you, how will you differentiate intermittent claudication from neurogenic claudication from osteoarthritis? So these are the 3 things where there can be some confusion and you need clinical points to differentiate them. So intermittent claudication, I'm saying vascular claudication, which we've been talking about. So vascular claudication, the pain is going to come after walking a certain distance. After walking a certain distance, that is when this pain will come. Neurogenic claudication, on the other hand, varies with posture. And this is the pain which occurs when there's lumbar canal stenosis. So when the nerves are compressed, lumbar canal stenosis, nerves are compressed and this can give rise to shooting pain along the leg. And this pain is relieved. Pain is relieved when patient bends forward. When patient bends forward, this pain is relieved. Okay. So this is neurogenic claudication. Osteoarthritis, pain is worse. Worse pain on taking the first step. On taking first step, that is when the patient will have worse pain. So this is how clinically we can differentiate these 3 conditions and you should know it for your exam as well. Now we discussed the 6 P's in acute arterial occlusion. In chronic arterial occlusion, because you have collaterals, you need to know that pain is felt in the muscle group. Pain is felt in the muscle group below the block, distal to the block, right? Below the block. And the most common site where the pain is felt is the calf, because you have the femoral artery which is commonly involved. So mostly pain is felt in the calf. Now symptoms depending on the site of the block, this is very, very important because this aortoiliac obstruction, that is Lerick's syndrome, has been asked many times in the exam. Now if there's aortoiliac obstruction, then there is going to be claudication in the gluteal region. So gluteal claudication is the earliest finding of Lerick syndrome This question has been asked many times in the exam. The earliest finding of Leydig syndrome or aortoiliac block is gluteal claudication. There can be absence of pulses, there can be bruit over the aortoiliac region, and there can be impotence in males. This is another thing which has been asked in the exam. So this is Leydig syndrome, which you should know. If there is iliac obstruction, then there will be claudication in the thigh and the calf, sometimes the buttock, and there will be unilateral absence of pulsations. If there is femoropopliteal obstruction, there will be claudication in the calf. Calf is the most common site where there is claudication pain felt. Femoral pulses are palpable, but distal pulses are absent. And if there is distal obstruction, then you will have claudication in the foot or the calf. This is for distal obstruction. So depending on the site, claudication can be felt in the muscle group below the block. The other clinical features in chronic arterial occlusion, so sensation is intact. Sensation is intact. The temperature equilibration is intact. So there in acute arterial occlusion, the limb was becoming cold and it was unable to equilibrate with the ambient temperature. But here sensations are also intact and temperature equilibration is also intact in chronic arterial occlusion. Also, these patients can present with an arterial ulcer. Arterial ulcer, I've discussed in the common ulcer module in detail about arterial ulcerations. So arterial ulcerations, you'll get absent pulsations. You will get absent pulsations. There'll be shiny skin. There'll be shiny skin, loss of hair, and you will get a punched out ulcer. And you will get a punched out ulcer, and there can be gangrenous changes surrounding the ulcer as well. So this is what an arterial ulcer looks like. For more details, you should also see the common ulcer module, where I've also covered diabetic ulcers in great detail. Now again, in these patients, the investigation of choice is a duplex scan or a Doppler scan. Investigation of choice is a duplex scan or a Doppler scan. This is what a Doppler, handheld Doppler machine looks like. Also, we should investigate the patient for cardiac problems, as cardiac problems can coexist with arterial or peripheral arterial disease as well. Now, by using the Doppler and by measuring the blood pressure, we can also measure one very important thing here, and that is ABPI. ABPI is super important for the exam. This is ankle brachial pressure index. This is ankle brachial pressure index is ABPI. And ankle brachial pressure index is defined as reading of maximum systolic BP in the ankle, at the ankle, divided by maximum systolic BP in the arm. So that is your ankle brachial pressure index, and you have to take multiple readings, and you will take the maximum value at the ankle divided by maximum value at the arm, and that's how you will get the reading of ankle brachial pressure index. Now, what all does this ankle brachial pressure index signify to us? If the reading is between 0.9 to 1.3, this is according to the latest Bailey and Sebastian. I'm telling you the latest values. 0.9 to 1.3 is considered as normal. Less than 0.9 is when intermittent claudication starts. Less than 0.9 is when intermittent claudication is going to start in these patients. Less than 0.5, you will get rest pain. And less than 0.3 is critical limb ischemia. This value has also been asked. This is critical limb ischemia, where necrosis is imminent. Where imminent necrosis is there, necrosis can occur below 0.3. Also, you should know that sometimes you can get a high value of ABPI as well. And high value of ABPI is seen in patients with calcified vessels. It is seen in patients with calcified vessels, and this is usually seen in patients with diabetes or chronic kidney disease. So these values of ABPI you should remember for the exam as they've been asked. frequently. There are certain other points which I want you to remember, which have been written in both Bailey and Sebastian regarding ankle brachial pressure index. So patients who have ABPI less than 0.5 are twice most likely to deteriorate. That means the disease is more likely to progress if the ABPI is less than 0.5. Gradually decreasing ABPI is a sign of imminent limb loss. In patients where resting ABPI is normal but arterial compromise is suspected, then we should do post-exercise ABPI. This is a very important statement. So in normal people like us, after exercise, ABPI will increase. ABPI is going to increase. But in patients with rate-limiting arterial disease, ABPI will fall. And this can predict that these patients will develop major arterial issues in the future. So wherever you have a doubt whether arterial problems are there or not, you do post-exercise ABPI, and if there's a fall in ABPI of more than 20%, that means the patient has arterial problems. And one final thing which you should know, for every 0.1 decrease in ABPI below 0.9, the risk of cardiac mortality goes up by 10%. So every time 0.1 value reduces below 0.9, then the risk of cardiac mortality goes up by 10%. So these are some important points regarding ABPI which you should know. Now, I told you about duplex scan being the investigation of choice, but in obese patients, it is difficult to visualize the iliac block, and that is why in these patients we can use an MR angio or we can use digital subtraction angiography. So digital subtraction angiography is also coming up in a big way to identify arterial blockade, as you can get reconstructed images where they tell you where exactly the site of the block is. So this is regarding the workup of a patient with chronic arterial occlusion. Now, the two main causes of chronic arterial occlusion which we need to discuss for the exam are Buerger's disease and atherosclerosis. So we need to discuss the differences of Buerger's and atherosclerosis. These are frequently asked in the exam. Now, Buerger's is commonly seen in the third or the fourth decade of life. This is commonly seen in the third or fourth decade of life, and males are more commonly affected than females. Whereas atherosclerosis usually starts in the fifth decade of life and beyond, and equal male to female incidence is seen here. Now, Buerger's disease, smoking is the main risk factor. Smoking is the main risk factor for Buerger's disease. For atherosclerosis, both in pathology and in medicine, you've read about the multiple risk factors for atherosclerosis. So I'm not going to enumerate all of them. You can have smoking, alcohol, type A personality, and multiple other risk factors have been covered in medicine and pathology. Now, Buerger's disease, again, lower limb is more commonly affected than the upper limb. That is the same case in atherosclerosis as well. Lower limb is more commonly affected than the upper limb. Buerger's disease involves the artery, vein, and nerve. All three structures, artery, vein, and nerve, all three structures are involved. And another name is thromboangiitis obliterans. Right? Here you can get superficial thrombophlebitis also, in addition to, you can get superficial thrombophlebitis in these patients. You can get neuropathy in these patients. And of course, there can be arterial blockade as well. In atherosclerosis, only the artery is involved here. Now, two things which govern the difference in presentation and difference in management of these two conditions. So you should know Buerger's, the spread is distal to proximal. The spread is distal to proximal spread, and it involves the small to medium sized vessels. small to medium vessels are involved. Whereas atherosclerosis is proximal to distal spread, and it involves the large to medium sized vessels. Large to medium vessels are involved in atherosclerosis. Now, in Berger's disease, if you do angiography, you will get corkscrew collaterals. So if angiography is done, you will get corkscrew collaterals. This you should know for your exam. Corkscrew collaterals are seen here. Corkscrew collaterals are seen if angiography is done in Berger's disease. This is an image of a patient with Berger's disease. You can see it involves the distal vessel, so that is why the toes are the ones which become gangrenous first. So you can see here in Berger's disease. Now let's talk about the management of these two conditions. So the management of Berger's and atherosclerosis. The management of Berger's disease, first thing is to prevent the patient from smoking, right? So it's to stop smoking. Otherwise the disease will keep on progressing. Now, this might seem like an easy task, but trust me, this is the most difficult task in a patient with Berger's disease. And I clearly remember a patient when I was in first year. That was the time when the patient first had his digits amputated of one of the limbs because of Berger's disease. 3 days after the procedure, he was caught smoking outside the ward. By the time I was in final year, he lost digits of his other leg as well. In first year of my senior residency, 2 of his fingers had to be amputated of one hand. And finally, in third year of senior residency, the fingers of the other hand were also amputated. Even after this, whenever he used to come to the OPD, the attendants used to tell us that he used to force them to put the cigarette in his mouth. So even without the digits, he used to ask attendants to put the cigarette in his mouth. That's how difficult it is for these patients to give up smoking. So these patients have to give up smoking, and we can use medicines in these patients. So I told you about pentoxifylline. Pentoxifylline can be used in these patients like it was being used in venous ulcers as well. And this reduces the viscosity, improves the microperfusion. So pentoxifylline has a role. Conservative amputations should be done in these patients with Berger's disease. I will tell you about conservative amputations. We'll discuss in detail. Now, no bypass grafting is possible in patients with Berger's disease. Why? Because it is involving small to medium vessels. The caliber is very small, and if we draw a simple diagram here, you can see here, we can see here that on this side is Berger's disease, right? So Berger's is involving these very small vessels, and it is spreading from distal to proximal. So even if I have to do a bypass, there is no distal target vessel because the target vessel is already thrombosed. So no bypass grafting because small vessels are involved, and there is no distal target vessel because the disease spreads from distal to proximal. There is no distal target vessel in these patients. So in these patients, we can carry out lumbar sympathectomy to reduce the pain. We can carry out lumbar sympathectomy. Lumbar sympathectomy can be done to reduce the pain in these patients. And lumbar sympathectomy is only done when there is rest pain. It is contraindicated in intermittent claudication. It is contraindicated in intermittent claudication. So lumbar sympathectomy is only done when the patient has rest pain, and it is contraindicated in intermittent claudication. Now, why is it contraindicated in intermittent claudication? Because what lumbar sympathectomy does is that it causes cutaneous vasodilation. It causes cutaneous vasodilation. And by causing cutaneous vasodilation, it is basically stealing blood or shunting blood from the muscles. Blood from the muscles, right? So when there is rest pain, the muscles are already dead. right? So to save the cutaneous supply, we can steal blood from whatever little blood is going in the muscles. It can go to the skin and it will reduce the pain for the patient. But in intermittent claudication, the muscles are still active. And if you steal blood from the muscles, you are basically precipitating rest pain, right? The patient who could walk, say 100 meters, now can't even walk that much because you've stolen all the blood from the muscles and given it to the cutaneous circulation. That is why it is contraindicated in intermittent claudication. Now, lumbar sympathectomy can either be done via the surgical method, or it can now be done via chemical lumbar sympathectomy, which can be done under radiological guidance. So you don't need to operate these patients. Under radiological guidance, we can do chemical sympathectomy in these patients as well. When we are doing surgical sympathectomy, please remember that the most common structure which can be mistaken for the lumbar sympathetic chain, most common structure which can be mistaken for the sympathetic chain is the genitofemoral nerve. And this question has been asked in the exam. So by mistake, if you cut the genitofemoral nerve, the patient's symptoms will not subside. Patient will keep on having the same symptoms. Now, when we are doing a lumbar sympathectomy, so you know there is L1, 2, 3, 4. L1, L2, L3, L4 ganglions are there. If bilateral lumbar sympathectomy is being done, L1 ganglion on one side needs to be saved. L1 ganglion needs to be saved on one side. Otherwise, this will give rise to impotence. Otherwise, it gives rise to impotence in males. That is why L1 ganglion needs to be saved on one side. This is a very important statement which you should remember if bilateral lumbar sympathectomy is being done. One final thing which you should know, omentoplasty has no role in patients with Buerger's disease. Omentoplasty has no role now. In earlier times, what was done was that the omentum was taken out through a small opening and it was brought right down till the leg. And they thought that because omentum has good blood supply, it will share its blood supply with the limb. But this surgery turned out to be a failure, so no omentoplasty. In Buerger's disease, we asked the patient to stop smoking. Lumbar sympathectomy can be done when there's rest pain and conservative amputations need to be done. That is the management of a patient with Buerger's disease. On the other hand, what is the management of atherosclerosis? So we discuss atherosclerosis is going to involve these bigger vessels. And when atherosclerosis is involving the bigger vessels, the management in these patients can either be angioplasty and stenting. And if angioplasty or stenting does not work out, then in these patients we can do bypass grafting. So these days, angioplasty and stenting is the first line treatment. This is the first line treatment in patients with atherosclerotic peripheral arterial disease. We do angioplasty and stenting. And angioplasty, the balloon is inflated for 30 seconds and then it is deflated. Successful for iliac and femoropopliteal, but the results below knee are less successful. That is why below knee grafts are preferred, whereas above knee angioplasty and stenting has shown good results. The complications of angioplasty and stenting, there can be bruising, bleeding, hematoma, and thrombosis can be there. If, of course, there is failure after angioplasty and stenting, then you have to carry out an open bypass grafting. You can see here, you can see the stent which has been placed, and after placing the stent, you can see that the blood supply to that area has increased. Now, bypass grafting, I told you bypass grafting will be done. If stenting does not work out, then we'll do bypass grafting. Now, if the block is in the aortic bifurcation, okay, so Leydig syndrome, like we discussed Leydig syndrome, aortoiliac block, supposing the block is here. So it is an aortoiliac block or Leydig syndrome. Here, what do we do? Here in these patients, we will have to carry out an aortobifemoral graft. right? Because we'll have to do grafting on both the sides. So we will have to do ioto-bifemoral graft here. Ioto-bifemoral graft. And this graft is above the inguinal ligament. It is an suprainguinal graft. So we have to carry out an ioto-bifemoral graft, and the best graft material to carry out this is Dacron. So Dacron is the graft material used for grafts above the inguinal ligament, and that is what we will do here. Now the second situation is that there is a block in the, if supposing there is a block in the iliac artery, if there is a single iliac artery which is blocked, right, then we can either do ioto-femoral or iliofemoral. So this graft will either be, so if there's an iliac block, we will again do either ioto-femoral or iliofemoral grafting would be done. And again, Dacron will be the graft material which will be used because this is above the inguinal ligament. This is done for iliac block. Now, if the block is more distal to this, if the block is in the femoral artery, then what do we do? So here, now if the block is in the femoral artery here, so this is our femoral block which is there. Now if there is a femoral block, we'll have to do an iliopopliteal graft. Okay, we will have to do an iliopopliteal graft. So femoral block, we will have to do iliopopliteal graft, and predominantly this graft is going to be below the inguinal ligament. This graft is going to be below the inguinal ligament. So when infrainguinal grafting is done, the best graft material for infrainguinal grafts is reverse saphenous vein. Reversed saphenous vein graft, right? It is a reverse saphenous vein graft, and I will show you a video of how this saphenous vein is harvested. So this is the reverse saphenous vein graft, which is the best graft material for infrainguinal grafts. The best synthetic graft material. Now, best synthetic graft material here is PTFE, but please remember that reverse saphenous vein is better than PTFE. So there are two questions, don't get confused. Best overall is reverse saphenous vein, but the best synthetic graft material here is PTFE. So let me show you this quick video of how this saphenous vein is harvested and what are the precautions which we need to take. So I've already told you about the surface marking for the great saphenous vein. It lies just anterior to the medial malleolus. And whenever we have to harvest the great saphenous vein, and where do we need the great saphenous vein? We can use it for infrainguinal grafting like I've just told you in this module. And this great saphenous vein can also be used for coronary artery bypass grafting. Right, so we make an incision all along the great saphenous vein and then we dissect the vein. You can see here we dissect the vein, and I told you below the knee it is closely associated with the saphenous nerve. So we have to be careful that we don't injure the saphenous nerve. Now once we've dissected the entire vein, we are going to cannulate the vein and then we cut the vein and we will have the entire graft with us. Now, when we are doing grafting, we usually reverse the vein so that the valves don't interfere in the circulation. So this was the management of Buerger's disease and atherosclerosis, and we've spoken about acute arterial occlusion and chronic arterial occlusion. We've discussed that if we don't intervene on time or if the patient comes late, the patient is going to develop gangrene. Gangrene is when there is microscopic and macroscopic death of tissue. Microscopic and macroscopic death of tissue, that is gangrene. And gangrene can either be dry gangrene or it can be wet gangrene. Let me show you the images and then we'll talk about the differences. This is a very common short note which is asked in the college exams where they ask you the differences between dry and wet gangrene. So this you can see is dry gangrene. This was a patient with Buerger's disease. You can see the line of demarcation is very well present there, and this appears as desiccated, dried up, shriveled up skin. Wet gangrene, on the other hand, the line of demarcation is not very well marked, and you can see oozing, you can see infection actively present in a patient with wet gangrene. Now, dry gangrene is desiccated tissue by gradual slowing of blood. and there is a good line of demarcation. Now this line of demarcation is the difference between, is the juncture between dead and living. Dead and living tissue, it is the junction between dead and living tissue. It is lined by granulation tissue. It is lined by granulation tissue. And this line of demarcation is very sensitive to touch, right? It is very sensitive, or there is hyperesthesia which is present here. So there is good line of demarcation in dry gangrene, and if the bone is also involved, then the stump is conical. Why? Because bone has better blood supply. So the bone line of demarcation will be more distal than the line of demarcation over the skin and the muscle. The bone line of demarcation will be more distal. Wet gangrene can occur when there is venous blockade or superadded infection. So this is another question which can be asked in the exam. Can a dry gangrene be converted into a wet gangrene? Absolutely. If there is superadded infection, a dry gangrene can get converted into wet gangrene as well. There is a poor line of demarcation, and there is infection which can extend to the neighboring tissue, and the line of demarcation can be more proximal, right? If there's infection, even the block might be distal, but because of infection, the line of demarcation might be more proximally placed. So these are the differences between dry and wet gangrene, which you should know about. Now, when there is gangrene, we have to carry out amputation. And the indications of amputations, you can remember them as dead, deadly, and damn nuisance. That's how we were taught in the exam, or that's how we were taught in college. Dead means the gangrene has set in. Dead means there is gangrene. Deadly means if there is gas gangrene, which can spread to the rest of the body as well. If there is a sarcoma which is involving the limb, if there is cancer involving the limb, that is a deadly limb. Okay, that is a deadly limb. And damn nuisance is when there are contractures which have developed in the limb which don't enable the patient to walk properly, or they are causing a lot of pain to the patient, or there are multiple sinuses or fistulae which have formed, or there is deformity which is not enabling the patient to be ambulatory. These are the indications when you have to amputate the limb. So we'll talk about certain points regarding amputation. This has been covered by Dr. Abbas in orthopedics as well, but I will tell you the points which have been mentioned in Bailey so that you're all sorted for your surgery exams. Of course, I wanted to share this image of Oscar Pistorius. He was a double amputee, both below knee amputation, and he was one of the fastest blade runners. So these new blade prostheses are used these days, and these patients can run very well, and he had an excellent career in front of him, but unfortunately he was convicted for murdering his girlfriend, and he's currently in jail. Okay, but I just wanted to show this picture that these patients, even after double amputations, can still have a functionally active life. So the key points which have been written in Bailey regarding amputation: when there is diabetes mellitus, local amputation of the digits should be done, and we should do conservative amputations. If the metatarsophalangeal joint is involved, then ray excision should be carried out. Transmetatarsal amputation, when several toes are involved, like in cases of Berger's or diabetes, if several toes are involved, then we can do a transmetatarsal amputation. Below knee amputation preserves the knee, and this gives the best chance of walking. This gives the best chance of walking, so you should know this. Below knee. And above knee heals well. The flaps heal well. Now, this is the amputation stump below the knee. You should know that it should be not less than 8 centimeters below knee. This question has been asked in the exam. The amputation stump should be not less than 8 centimeters. Ideally should be 10 to 12 centimeters so that a good prosthesis can fit there, right? So why do we want this much length? So that a good prosthesis can fit there. There are 2 ways to do a below knee amputation. More commonly, we do a long posterior flap, or the other one is a skew flap. Now, long posterior flap is more popular, and the anterior mark is 10 centimeters below the tibial tuberosity. The anterior mark is 10 centimeters below the tibial tuberosity. So here you can see the marking for below knee amputation. You can see a long posterior flap. This is how the amputation is done, and this is how it heals up. A long posterior flap, you can see the posterior skin coming forward. This is the more popular type of flap which is made during amputation. For above knee amputation, not less than 20 centimeters length should be there for the prosthesis to fit in. Right, so these points you should remember for the exam.